Welcome to Advanced Pharmacology. We will be having a discussion of Esmolol, Vecuronium, Ropivicaine, and Ketamine. Let's begin with Esmolol. Esmolol is a beta-1 cardioselective additive receptor blocker. It's supplied in either a 10 cc vial or a 250 cc bag, each with a concentration of 10 milligrams per cc. Some manufacturers also offer higher strength version in a 100 cc bag at 20 milligrams per cc. When administered, it attaches to the beta-1 receptors in the cardiac tissue. It competes for these sites with catecholamines such as norepinephrine and epinephrine. The result is a reduction in cyclic AMP levels. This results in a reduction in phosphorylation of ion channels and ATP pumps within the cells. The ultimate result is a reduction in inotropy, chronotropy, dromotropy, and cardiac output. Now, here we see the action of a beta-1 GS receptor without the effect of the Esmolol. Once we add the Esmolol, it inhibits the attachment of the epi or the norepi, and the result is none of the later things happen, and you don't have the phosphorylation and all of the increases that you would see. When used in the anesthesia setting, it's administered intravenously in IV push doses of 25 to 100 milligrams. You can also infuse it through an IV pump at 50 to 300 micrograms per kilogram per minute. It has an extremely rapid onset, which makes it so useful for anesthesia, of 1 to 2 minutes. Its peak is about 5 minutes. As for its elimination, the T1/2 alpha is only about 2 minutes. Now, this is the amount of time required for the level in the blood to fall by 1/2 related to redistribution. Its T1/2 beta is about 9 minutes. Now, this is the amount of time for half the drug to be actually eliminated from the bloodstream and also from the body. Its metabolism is through erythrocyte esterases. It's used mainly for rapid short-term rate control of supraventricular tachycardias, such as atrial fibrillation, atrial flutter, and atrial tachycardia. It's also used perioperatively to control these various forms of tachycardias with or without hypertension. For example, when they occur during induction and intubation. They're also used throughout the surgery, during emergence, or in the immediate postoperative period. One of the main reasons why it's such a good choice is because it has such a rapid onset and such a short duration. Contraindications include known hypersensitivity, bradycardia, heart block greater than first degree, cardiogenic shock, overt heart failure, and hypertension associated with hypothermia. as well as tachycardias that include hypotension, as the reduction in the rate may further reduce cardiac output. Relative contraindications, depending on the variety of factors, include hypotension and congestive heart failure and a history of bronchospastic disease. These conditions can be exacerbated in a dose-dependent manner. When administered to a diabetic, it can have the potential of masking tachycardia associated with hypoglycemia. And in patients with renal impairment, there's a possibility of a buildup of a renally excreted acid metabolite. Next, we're going to look at Vecuronium, also called Norcuron. Vecuronium is a non-depolarizing nicotinic M neuromuscular blocking agent. It's also in the category of immunosteroid. Typically, it's supplied in 10 or 20 cc vials at a concentration of 1 milligram per cc. Vecuronium acts as a competitive inhibitor to acetylcholine on the nicotinic M-type receptor at the postsynaptic neuromuscular junction along the motor end plate. It attaches to the alpha subunits of the receptor, preventing the receptor from opening. When approximately 90% of these receptors are blocked, the motor end plate will become incapable of reaching threshold, and you will have relaxation of the muscle. Here we have an example of a nicotinic M receptor on the motor end plate being acted upon by molecules of acetylcholine. Notice how when they attach, the receptor opens and the sodium ions rush in. And here we see the action of Vecuronium when it attaches to the nicotinic M receptor. It inhibits the binding of the acetylcholine, and the receptor does not open, and the neuromuscular end plate does not depolarize. Vecuronium can be used intravenously to achieve muscular relaxation for adult endotracheal intubation. The IV dose is approximately 2 times ED95, which is a range of about 0.08 to 0.2 milligrams per kilo. It can also be used for rapid sequence intubation, but you need to increase the IV dose to 3 to 4 times the ED95. The range is 0.15 to 0.4 milligrams per kilogram. You can also give a priming dose to hasten the onset of the neuromuscular blockade. Priming dose is approximately 10% of 2 times ED95. During surgery, it can be used for maintenance of surgical relaxation. This can be achieved through an IV infusion of approximately 0.8 to 1.2 micrograms per kilogram per minute. When Vecuronium is used for intubation, the onset for favorable intubation conditions in non-emergencies when 2 times ED95 is used, the onset is approximately 2 to 3 minutes. The duration of action until return of 90% of a train of 4 is approximately 50 to 80 minutes. Vecuronium is metabolized mostly by hepatic metabolism, approximately 75 to 90%. It has an active 3-hydroxy metabolite, but since it is mostly hepatically metabolized, it makes it a very good choice for patients that have renal dysfunction. The main contraindication to Vecuronium is a known hypersensitivity. Prolonged recovery times have been seen in patients that have liver failure, or when it's used on a long-term basis, like that in the ICU. Pain control and or sedation must be used while on Vecuronium, since it has no sedative effect or pain control effects. Neuromuscular blockade can be prolonged if used with a volatile inhaled anesthetic. It's also been seen with use of local anesthetics and aminoglycoside antibiotics. Vecuronium is a weak acid and should not be mixed with alkaline solutions such as thiopental and other barbiturates, as this will result in a precipitation.
Ropivicaine is a local anesthetic drug belonging to the amino-amide group. It is typically supplied in a concentration between 0.2% and 1%. It was synthesized in response to a need for a long-acting local anesthetic like bupivacaine with motor sparing and lower toxicity similar to ropivacaine. When administered, it reversibly binds to the intracellular portion of voltage-gated sodium channels, segment 6 of domains 1, 3, and 4. This increases the action potential thresholds for electrical excitation in the nerve, thus slowing the propagation of the nerve impulse. In general, the adequacy of anesthesia is related to the ability of the local anesthetic to penetrate nerve fibers and is based upon the diameter, myelination, and conduction velocity of nerve fibers. This is an example of ropivacaine acting on a voltage-gated sodium channel. The highly lipophilic and uncharged molecule passes through the lipid bilayer into the cytosol. Once there, it becomes charged and preferentially binds to the interior of an active sodium channel, preventing the free flow of ions through it. Typically, ropivacaine is used for creating an epidural block for surgery including cesarean section, major nerve block, or local infiltration. It is also used for acute pain management through continuous epidural infusion or intermittent bolus, postoperative, or labor. Ropivacaine is contraindicated in patients with a known hypersensitivity to ropivacaine or to any local anesthetic agent of the amide type. Ropivacaine is contraindicated for IV regional anesthesia. However, new data suggests that ropivacaine 1.2 to 1.8 milligrams per kilogram can be used because it has less cardiovascular and central nervous system toxicity than racemic bupivacaine.